Yeah, thank you, Dr. Sonu, for including me. This one of the very important instruction course. I think most of my talk is already covered by Dr. Sonu, so I need not have to talk much. Only within couple of minutes, I can finish my talk. So, as I think everybody has been discussed that what is the indication for this ICL, but the number of ICL implantation nowadays to treat low and moderate myopia is increasing because not everybody can afford for buying a big refractive equipment. So the incidence has been increasing, and even doctors are started using more these phakic lenses. But when the increased surgical number, then possible complication also you can expect. So probably, as Dr. Sonu said, that the central hole in the phakic IOL was a significant improvement in the design, because the previous model what I started almost 14 years before, there was some patient used to come with the cataract formation, also increased in the intraocular pressure. Probably the central hole improves the aqueous humor circulation, preventing many of these complications without any need of any peripheral iridectomy. So probably complication do happen, but if you ask me, most common ones are due to the inadequacy in the vault. So if the, as Dr. Sonu said, that if phakic IOL is properly placed, the separation will be exit between the posterior surface of the phakic lens and the anterior surface of the crystalline lens. So the term vault refers to this place. So what should be the ideal vault? The ideal size is between the 250 to 750 micron, that is around half corneal thickness to the 1.5 corneal thickness. So as Sonu said, that the undersized lens, that is less than 125 micron, may increase risk of anterior subcapsular opacification, and oversized lens, that is more than 1000 micron vault, may push the iris forward and close the angles, which would lead to the increase in the intraocular pressure and with the iris malfunction. So normally, as you said, that how vault can be measured with the help of anti-segment OCT by accurately, or even with the help of simple slit lamp, you can even measure manually also. So undersized ICL can lead into low vault, oversized IOL can cause into a high vault. So once again, vault is directly correlate to the size of the phakic lens. That is very important. See here, anterior segment OCT showing a normal vault post-operatively. You can see ideal vault. But here, if you can see here, patient, the anterior segment OCT showing a high vault post-operatively. You can see there is a pupillary block also, and also there is an increased risk for angle closure glaucoma. See here, patient with a low vault post-operatively, and you can see, like here the previous picture, you can see the vault is almost around 793, almost 800. Here if you see here, it is the low vault where you can see around 296. That is much lesser. There is a very risk of patient developing anterior subcapsular opacification. This is about the slit lamp examination, how exactly high vault looks like, and how exactly the low vault looks like in the slit lamp examination. So this is a schematic image. I think it can shows that how exactly it correlates with the external white to white and the internal measurement, angle to angle, and sulcus to sulcus distance, and the lens size is relevant to the size of the phakic lens. I think this can, I think Dr. already Kamal has been talked to in his presentation. So these are the different equipment. Once again, as I said, that vault means it is directly correlate to the white to white measurement. These are the different equipment which can give you the white to white. I think already Dr. Kamal has been discussed. I am not talking much about this, but in my place, my normal how I do, I take a digital calipers, I calibrate the digital calipers. First I take white to white, then I'll tell my senior consultant, he also go to the OT, simultaneously he measures, then we correlate with the two readings along with the help of even IOL master, which gives a slight increase in the white to white. Then in the end we order. So ordering the ICL is very important. If you order perfectly, I think you will not have. See, this is what the white to white with the orb scan, always the previous model of orb scan, which gives the accurate result. But IOL Master 500 again, it gives oversized vault, oversized white to white. You have to be very careful with this. So this is how what I just told. Again I keep discussing again mid limbus to the mid limbus. What I do in my this thing, I am going ahead with the mid limbus to the mid limbus. See, this is how you do with the digital calipers. Exactly how you take the measurement. Patient has to be in the operation theater, in the supervised position, take it, and once again I take it, and in front of the scale also I measure. So this is about the white to white. The white to white digital CAD should be under the microscope in high resolution, mid limbus to mid limbus. Or you can use OBSCAN to validate caliper measurement, the old model of OBSCAN. If you have got a IOL master, make sure that you validate. Some reports of IOL master again overestimates the white to white. Be careful if the patient is having pterygium, even pigmented area around the cornea. Evaluate the discrepancy between the measuring device and between the eyes. Both eyes should be about same white to white. This is very, very important. So as UBM, ultrasound biomicroscopy, probably helpful in is the that provides the information post iris which cannot be evaluated through slit lamp microscopy, and in fact it is the only one instrument which can give the actual sulcus to sulcus measurement, which could exactly ascertain the size of the phakic IOL. But to do UBM, you have to do the hundreds of UBM. You become yourself the best. So UBM to become best is much important. Post-operatively, it evaluates the appropriate position of the phakic intraocular lens, posterior chamber, including optic zone, bilateral haptics, relation to the iris, crystalline lens, zonules, and ciliary body. These are what we do it with the UBM, sulcus to sulcus measurement. So coming to the management of the high vault, Sonu already told, vault beyond 750 micron, the possibilities of developing glaucoma and narrowing the angle. In case of plane or spherical phakic, as Dr. Sonu said that, rotate the IOL from horizontal to the vertical position, as this lowers vault by around 200 microns. This is very, very important. So why it is? Because the vertical white to white is higher than the horizontal white to white. Okay. So you have to remember, if you rotate, I think 200 micron will come down. You can repeat the gonioscopy every visit to note the development of the antrasynechia. Toric phakic even lens with a high vault 1000 micron, probably you may have to think about for the phakic IOL exchange. Coming to the management of low vault, if the vault lower than 250 micron, watch. In case of toric phakic IOL with a low vault, chances of rotation is very high. Cataract is probably the most common complication. Do a dilated fundus examination in every follow-up. Note for peripheral development of the lenticular opacity. If present, plan for explant. Exchange with the right sized ICL is very, very important. Cases reported vault even less than 125 micron can also left alone, probably with the recent form of even central hole. In conclusion, phakic intraocular lens have changed the course of the refractive surgery. With the new designs of newer companies of phakic IOL, due diligence is required about the vault measurement too. Vault measurement is important as can make or break the success of the surgery. Use of newer technology for diagnosing, measuring, planning of surgery that helps in prevent major complication later on. Calibration and validation of measuring white-to-white equipment is of absolute importance. Once again, I thank my brother Sonu for this wonderful opportunity. Thank you, Anand.
Thank you, Krishna, for that excellent talk. And I think all the questions, most of them are answered.